Can you start the countdown?
Just a minute.
Good evening, friends. Welcome you once again to a brand new episode of GICS Rapid Journal Review, where we dissect some of the very important and interesting recent articles of intensive care medicine. The revised Atlanta classification had walled off acute pancreatic necrosis to 4 weeks. Till the wall of necrosis is formed, the capsule is formed, it was advisable that the drainage should be performed only thereafter. However, there are several studies which pointed to attempted earlier drainage procedures before 4 weeks in the event of organ dysfunction and in the event of organ failure and infection. Although there were intriguing results, and often one defined the limitations where the other began. One of the recent studies in the recent times found no difference between early and late intervention in acute pancreatic necrosis. And then came the recent study, the timing, which was published this year in the intensive care medicine. Tonight, we will be joined by our experts. We will have Dr. Sunil Karant from Manipal Hospital, Bangalore as our expert panelist. Welcome you, Sunil, in GICS Rapid Journal Review.
Thank you.
We have our regular panels, Dr. Shobhik Maitra from All India Institute of Medical Sciences.
Good evening to all.
Welcome, Shobhik. And Dr. Pradeep Rangappa, as usual, from Bangalore.
Good evening, Anil.
We will be joined shortly by Ajit as well. And most importantly, today, the study will be presented by Dr. Chetan Vamshi from AIIMS Jodhpur and will be mentored by Dr. Sadiq Muhammad. Welcome, both of you, Dr. Sadiq and Dr. Chetan. And without wasting any further time, I will request Dr. Chetan to present the timing randomized control trial.
Good evening, sir. Sir, are my slides are visible, sir?
Yes.
Please am I audible, sir?
Yes.
Yeah.
Good evening to all respected.
Just one slide, you shift and come back just to see if it's
moving. Is it moving, sir?
Not really. Yeah, that's fine. Yes, go back. Thank you.
Thank you. Good evening to all respected dignitaries. Thank you for giving me the opportunity for journal presentation in GICS Rapid Journal Review. As Sir said, today's topic for the discussion is early versus delayed catheter drainage for patients with necrotizing pancreatitis and early persistent organ failure, a timing trial. This is a Chinese-based multi-center randomized control trial. This article was published on July 14, 2025 in the Journal of Intensive Care Medicine with an impact factor of 21.2. Dr. Chetan, I am DM Critical Care Medicine Trainee, AIIMS Jodhpur. Introduction. As we all know, acute pancreatitis is one of the common GI disease with a variable clinical course, and severe acute pancreatitis, which is defined by modified Atlanta classification as persistent organ failure for more than 48 hours, has a high mortality risk of up to 43.8%. Early organ failure often develops within first few days due to severe inflammatory response syndrome, and many severe cases do develop acute necrotic collections as an early local complication of pancreatic necrosis. Most of the acute necrotic collections remain sterile and resolve spontaneously. Therefore, ECG guidelines also recommend delayed intervention to avoid any infection risk. rationale for this study, and what are the existing evidence gaps. Symptoms of sterile inflammation and infection do overlap in acute necrotic collection patients with early persistent organ failure, especially in the second, third week. And many of the observational data also suggest that early intervention might offer clinical benefits by one, preventing early infection of necrosis, second, reduce the inflammatory mediators that worsens the organ failure, third is the decrease in the intra-abdominal pressure. However, no large RCTs have definitely compared early versus delayed intervention in patients with acute necrotic collections and early persistent organ failure. So this trial was designed to address this critical clinical question. The same team had previously conducted a small pilot trial, sir, that demonstrated early percutaneous drainage triggered by the development of organ failure rather than infected pancreatic necrosis was safe and did not increase the risk of infection and might improve clinical outcome in patients with acute necrotic collections. And this article was published in Journal of Hepatobiliary Pancreatic Sciences in 2021. This was the multi-center open-label randomized control trial, and 5 tertiary teaching hospitals in China with expertise in pancreatitis management were assigned, and they included the population with age between 18 to 70 years of age with acute necrotizing pancreatitis, and CT confirmed and accessible acute necrotic collections, and patients with early persistent organ failure. The study was between 2019 March to 2022 April, and there was an 8-month COVID break in 2020. The primary objective of the study was to whether early percutaneous catheter drainage of acute necrotic collections does improve clinical outcomes compared to standard guideline that is recommended as delayed intervention in patients with acute necrotizing pancreatitis. The main outcome measured for this objective was composite endpoint of major complications and or death occurring during the index hospital admissions. Secondary objectives were individual components of composite endpoints. What was the number of organ failure free days, that is post randomization up to 21 days? What was the incidence of infected pancreatic necrosis, incident of onset of sepsis, symptomatic splenic vein thrombosis occurrence, and other procedure related outcomes, resource utilization, and hospital free days, ICU free days, or 90-day mortality post randomizations. They included the patients with diagnosis of acute pancreatitis within 7 days of onset of pain abdomen, and patients with persistent organ failure, worsening organ failure, or new onset after 7 days, and acute necrotic collections, those demonstrated by CD and those which are accessible for percutaneous drainage. They excluded the patients with pregnancy, chronic pancreatitis, tumor-related pancreatitis, if there are prior intervention to acute necrotic collections, history of CPR or severe comorbidities, and pre-randomization screening was done between week 2 and week 3 for organ failure progression or persistence. They did a permitted block randomization with variable block sizes. Computer generated randomization sequence were assigned, and assignments sealed in opaque envelopes which were opened only after the consent. As given the nature of the study intervention, sir, this trial was open label. However, outcome assessor and the trial statistician was blinded to patient allocation and at the time of analysis, respectively, sir. Coming to the procedure in the early intervention group, they preferred percutaneous catheter drainage and no endoscopy within 24 hours post randomization. And drain removal were like if the drain output was less than 50 ml per day for 3 days and there were no infections. Daily monitoring for drainage volume and infection signs and symptoms. Whereas in the standard K group, timing of the procedure was only if the infection develops, percutaneous or endoscopic, and clinical lab and CT assessment for infection. Other standard management like pain management, nutrition, fluid, and antibiotics were in the same same for both the intervention as well as standard groups. Electronic data capture system used for real-time recording, and all interventions and outcomes were carefully audited and analyzed. They did sample size calculation based on the previous trial data, expected that 50% of standard care would face the primary outcome, and with 25% absolute risk reduction, the sample size came up to 120 participants to achieve 80% of power. Analysis populations were of 2, one intention to treat and one per protocol. Intention to treat are all the randomized patients which are analyzed in the assigned group, whereas per protocol patients were those patients who strictly adhered to protocols. As we statistical methods, Shapiro-Wilk test for normality, mean plus standard deviation or median interquartile range for continuous data, percentages and counts for categorical data, Fisher exact test, student t-test, Mann-Whitney U-test as suitable for the variable types were used, generalized linear models for comparing the outcome incidence and reporting risk difference and relative risk with 95% confidence interval, Kaplan-Meier curves for 90-day mortality and compared with using a log rank test. And test was considered as statistically significant with if p-value less than 0.05. Results, overall 531 patients with necrotizing pancreatitis were screened. Out of them, 120 patients were randomized. With 63 patients to the early intervention group and standard care group had 57 patients. All the patients had followed completely till the study. And these were the key baseline characteristics of the population group. Median age was 42 years, 77% of the patients were male. Most common etiology found was hypertriglyceridemia and primary organ failure most commonly, and in most all the patients were respiratory. This is the consort diagram, which shows total 531 patients were screened. Among them, post randomization, there was total 120, and with 63 allocated to intervention group and 57 to standard group, sir. Among 63, all the 63 patients received allocation intervention, sir, except 2 patients. One resolved spontaneously and shifted to ward, and other patient didn't give the consent but gave the consent for the follow-up. There were no loss to follow-up in the intervention group as well as in analysis group and in the standard group. In the standard group, among 57 patients, 56 patients received intervention, but one patient was not in per protocol group because one patient did have percutaneous drainage within 4 days post randomization, and the cause was not mentioned in the study. And overall, 61 patients of intervention and 56 patients of standard group were analyzed, and the results got published. The primary outcome was the composite major complication and death, and this composite includes either new onset organ failure, bleeding requiring any intervention, GI perforation or fistula needing any intervention, or death during index admission. Overall, in early intervention group, the composite complication was 33.3%, whereas in standard group were 36.8% with p-value 0.69, and no significant difference was achieved in the primary outcome between the two groups. Among the major complications, overall in-hospital death was 22.2% in early intervention and 19.3% in standard care group. And major complication, new onset organ failure, cardiovascular were almost similar in both the group, and bleeding needing intervention was slightly higher in the early intervention group among like 11 patients out of 63 patients versus 9 out of 57 patients in the standard care group. This was the primary outcome published in the journal. This was the secondary outcome. Secondary outcome as death 90 days post randomization and post randomization 21 days. Infected pancreatic necrosis, sepsis, pancreatic fistula were almost similar in both the groups. Intervention related outcome and adverse event. Recipient of percutaneous drainage, like 97% of all the patient in early intervention group, but less than 50% patient in the standard care group. And drain days from the onset to the first intervention was median range was 9 days in the early intervention group, whereas 17 days in the standard care group with a difference of 8 days. Overall adverse events was 25.4% in the early intervention and 12.3% in the standard care group with p-value 0.007. Although it is not statistically significant, it was clinically significant. This was the cumulative proportion gap, proportion curve with x-axis showing organ failure free days with y-axis of proportion of patients, and distance between the two curves shows the difference in the distribution of recovered days. And as the curve demonstrates, no meaningful difference between the early intervention versus the standard care group. This was the other visual comparison by color-coded bars, where the blue indicates the best prognosis, yellow indicates the worst prognosis, and again the distribution between the blue and the yellow was similar in both the groups. Discussion, the main findings, the primary outcome, early intervention did not reduce the composite incidence of major complications and or death compared to the standard delayed approach. Almost half of the patients in the standard care group improved without needing any invasive intervention. And it was also compared with previous study, that's the Pointer trial, one of the landmark trial published in NEGM by Netherlands, also found no benefit in immediate drainage of infected necrotic pancreatitis compared with delayed drainage. The difference was Pointer trial included severe patients with only acute necrotizing collections, but timing trial, they included non-infected acute necrotizing collection as well. Strengths and the limitations of this study was strengths were randomized design across uh, five, uh, five high volume expert sites and strict protocol adherence and complete follow-up for all the patients. Intention to treat and sensitive analysis was strong. Limitations were sample size were relatively small and findings need confirmation in larger studies. Predominance of hypertriglyceridemia as a cause may vary and cannot be generalizable across the geographical location. However, subgroup analysis found no evidence in the etiology causing the outcome. COVID-19 pause may have introduced the selection bias. And in the standard care group, the gap between the intervention timing was shorter than the ideal. That was the difference was 8 days, which could have reduced observable differences between the groups. Final conclusion is early catheter drainage in patients with necrotizing pancreatitis and early persistent organ failure did not improve the outcomes versus standard delayed infection guide care. The observed high rate of adverse events in early intervention further argues against early catheter drainage. Final recommendation is continue the following current recommendation according to ACGE, that delayed intervention until clear signs of infection present, while awaiting results from larger possible multicenter studies to confirm these findings. And the practice of not intervening early unless absolutely indicated is still safe and may prevent unnecessary risk and costs in high risk population. Thank you, sir.
Thank you, Chetan. Very nice presentation, and we got to understand the various aspects of the study. And this is a very nicely conducted study. And before I move on to the questions with our experts and the regular panelists, I wonder if Sadiq, would you like to add anything more to what Chetan Vangshi has already presented?
Sir, good evening, everyone. Although this presentation was prepared under my guidance, and one thing which I want to highlight is that we don't know that in the intervention group, at the time of intervention, how many patients were actually having an infected necrotic collection. It is a possibility that the patients in the intervention group might be having infected necrotic collections at the time of intervention. That's why they are not able to find out the difference between the control and
we will discuss that, Sadiq. We will discuss that in course of time. So moving on to I move on to Shobhik with the first question. To begin with, Shobhik, if you look into this study, first point that strikes me, 530 people were eligible and only 120 randomized. So the generalizability of the study comes into question, and 5 centers with 120 patients, 24 patients in each center. What is your take on that?
So you have aptly said that around 400 patients, probably more than 400 patients, were excluded after assessment. So only 120 patients were randomized. So the technique, these seriously questions the feasibility of the technique in real life scenario. Number one. Number two, and with the particular inclusion criteria decided by the study authors is actually very limited. So applying these techniques at bedsides and stick to the inclusion criteria decided by the authors is practically that will cater only a very small group of patients. And considering the heterogeneity in acute pancreatitis because of the different cause and mainly cause, so 120 is actually very small sample size. So obviously it is expected that inclusion of 150 patients in this scenario from a cohort of 530 patients, which excludes more than 400 patients. And one interesting thing in that concert diagram, it shows that organ failure resolved during screening period, that was 138. So which is of importance because these 130 patients actually improved during this period. So if we extend the follow-up period up to 4 weeks, so another group of significant number of patients they will never require an intervention probably. So there is a definitely group of patients who would never required an intervention if we have just followed them and screened for infection and development of persistent organ dysfunction. So this table clearly indicates the flaws, or not, I'll not say flaws, the limitation of the design in the design of this study.
Very correct. Fully agree with you, Shobhi. Sunil, when we look into the data, we find that more than half of the patients, or nearly half of the patients with pancreatitis, had triglyceridemia.
Yeah.
How common it is? Number
Yeah.
one.
So
Yeah.
yeah. Yeah, so I think that is definitely a negative aspect of the study, because the validity, or what the external validity of that across other parts of the globe may not be very much, because as we know, the top two causes for in our setting is gallstones first, followed by alcoholic pancreatitis. Again, there may be regional differences, but on the whole, I think now the gallstone seems to be top of the list, followed closely by alcoholic pancreatitis. And also, it's important to understand that the prognosis of pancreatitis also depends on the diagnosis or the etiology. So these would be the top two sort of etiological things, which also have a poorer outcome compared to a lot of other types of acute pancreatitis. So I think in that context, the validity of its or the generalizability of the study is questionable. Yeah.
I also go to with you with the second part of this question. I will come to with the same question to Sadiq after that. If you look into the causes of organ failure, you will find that 96% of these patients had respiratory failure. Now, when you have acute pancreatitis, which leads to abdominal compartment syndrome due to intra-abdominal hypertension, you expect at least an appreciable percentage of patients will also have renal failure, which in this case is absent because 96% of the patients going into respiratory failure. Now, how do you think that is it skewed, or is it something we need to really worry about, that the patients may not have any renal failure and they may directly progress to the respiratory failure?
Yeah, so I would say that is probably also related to the etiology. Majority of them coming from triglyceridemia, probably that also contributes, because there is a theory that alcoholic pancreatitis itself can have a poorer outcome considering the nature of how it causes pancreatitis. Yeah, but that apart, definitely, though we also see probably ARDS is probably, or lung failure or lung dysfunction is higher than AKI. But then AKI percentage, at least from our data, seems to be much higher. So that's definitely could indicate that probably the patients are not very, very ill as compared to what we would see. And the question of generalizability about,
Yeah,
again,
so
comes into the
that is something. You want to add anything to that, Sadiq, to the same point?
Sir, I want
You
to add one thing, that it depends upon the definition of renal failure and definition of the respiratory failure also.
Yeah, quite right. Yes, Sadiq, you are muted. You have to unmute yourself.
Oh, so I just wanted to highlight the same point which Souvik has highlighted, that they must have defined the
But
respiratory
Sadiq, I
failure.
get your point about the definition, but you also see they use the modified Marshall criteria,
Yeah.
and they also use the this SOFA. Now, SOFA was for the cardiovascular and respiratory. They use the Marshall, I think, score of more than 2, or
Yes, sir.
more than greater than equal to 2 for SOFA, which they used. Now, do you think that this probably, if so that the scoring system will also have something to do with determination of the organ system failure?
Definitely, it affects the means so finding out the means depending upon the definition of scoring used, one patient may fit into the respiratory failure, and at the same time, the same patients may not fit into the respiratory failure if you use the other criteria for defining the respiratory.
So that is also important. Pradeep, you are there? If yes, I will go to
Yeah,
Pradeep.
yeah.
I will move
Anirban,
on to
I'm here, but I'm just traveling. But yeah, I can.
Okay. So
Yeah.
if I go to Pradeep with the next question, that if you look into the Pointer trial, which compared within 24 hours drainage in case of infected pancreatitis, versus this trial, which particularly wanted to look into any or persistent organ failure. We know that any organ failure of more than 48 hours, it constitutes as a severe form of pancreatitis as per the revised Atlanta classification. And we
Yes.
also know that this organ failure in this study, they persisted for more than 7 days, on the contrary. So is it really practical to expect organ failure without any infection vis-a-vis infection without organ failure in the context of this study? Because pointer study looked at infection, and
Yeah.
that infection was followed by organ failure, which seemed quite natural, rather than in this study where the infection was treated as a different entity from organ failure, and even new onset of organ failure was also defined without any regard to infection. Now, in the setting of pancreatitis, how practical it is to think of organ failure and infection as separate entities.
Yeah. So Anirban, I think the author clearly pointer actually that came in NEJM in 2021. It was a very similar trial as to this particular timing trial. But if you notice in the pointer trial, the authors do say that only 20% of them had organ failure. And 35% of them who had infections which were treated got completely better. And even that trial was very similar to this, in which there was no difference found between. So it is little different that in that particular trial, they took infection as a criteria to randomize between the percutaneous and the standard. But here they have taken organ failure, albeit the pointer trial, only 20% had organ failure. So there is some element of superiority in this. But having said all that, in this particular trial also, I think they had done gram stain from the aspirate, and they did have infection, isn't it, in the both groups?
That was in
So,
pointer trial.
no, I think in this also, I think there was a mention in the
too.
methods. Yeah, in this particular study also, there is a mention. They did the percutaneous drainage and there was infection. So they are similar, but I believe the timing has a better merit because they've taken with organ failure in both groups and all the patients with organ failure. That was the inclusion criteria. So in that way, it stands out to be different.
Fine, fair enough. Sunil, would you like to add anything on that perspective of organ failure and infection as separate or distinct or entities, or as in the same continuum?
No, I think it would be more or less in the same continuum, because again, the inflammation of pancreatitis itself can actually lead on to organ failures. Now, whether a new infections coming unsettles it, causes this thing, which was one of the inclusion criteria for them, new organ failure persisting beyond a week. So probably they have not differentiated infections, or at least that was not the goal of the study. It was only to see of multi-organ failure in general. They have not certainly looked at whether the organ failure occurring because of infection caused more problem or not. I think that is not the focus of the study, so probably that's not been looked at. But in general, yes, I think the pancreatitis itself can be enough reasons for multi-organ failure, including AKI. So I think that's where I would leave it at.
Very, very true. Shobhika, another point I will true that this study included only percutaneous drainage by ultrasound and CT guided. Although we know that a good proportion of of such drainages as per the step-up approach, which is the normally recommended drainage strategy currently, a good number of such procedures are carried out by endoscopy. Number one, the transluminal drainage using endoscope, and by the video assisted this retroperitoneal debridement, the what they say. So probably it would have been good for if the investigators had also included these strategies, which are gradually replacing the the percutaneous drainage.
Exactly. If we even go back to the concept diagram, it also says that not technically feasible. So around 20 patients, 19 patients where the percutaneous drainage was not technically feasible, number one. Second group of patient would be that there is no improvement in the organ failure after drainage, or the drainage, actually the percutaneous drainage failed to cater the problem. So there will be two scenarios. One, it is not technically possible because radiologically drained. Second, it is not draining. Even if you have attempted a drainage, but you failed. So there should be a role of rescue strategies. Though the surgical drainage are extremely rarely done nowadays, and particularly patients with organ failure, they are actually not done, in almost never done until unless it is absolutely necessary, like GI perforation or bleeding, some other causes are there. It is rarely attempted in nowadays. But yes, the endoscopy guidance could have been used at least as a rescue strategy in a selected group of patients where the primary therapy fails. or it is not technically feasible. That could have been done.
Yeah, I just don't, I think they have specifically mentioned this, that why they have not used endoscopic techniques. If you look at somewhere in the
Yeah.
discussion that, because they wanted to quantify the drain loss. And the
Yes.
second thing also is, I think, see, to do an endoscopic approach, not so much probably the video assisted, but endoscopic, you really need a well walled off kind of
Yes.
collection. Otherwise, if it is still quite diffuse, quite this thing, it is not going to work out. So I think they
It
did
is very
have.
difficult to do in second week and third
Correct,
week.
correct.
So the
It's
step up
probably,
approach.
it was too early for them to consider doing endoscopic, even if they wanted to, because it was not really a walled off collection, and it's probably only
Yeah,
going to cause
but
more harm.
Sunil,
Yeah.
when there were certain collections which were not amenable to percutaneous drainage with the standard technique, which they have identified, probably on those patients they should have tried
But
endoscopic
I
drainage.
thought they have excluded those patients because one of the
They were
criteria was
excluded.
to
They were
actually
Actually,
have
actually they
percutaneously
excluded.
approachable. So that was
Yeah.
anyway
Actually,
not the inclusion criteria. So
Yeah.
yeah,
So if you look into the step up approach, the step up approach says the first approach to drainage should be percutaneous drainage
true, true.
or this endoscopic drainage.
Yes, yes.
Second stage should be the minimally invasive necrosectomy, including the VERD, that is the video assisted retroperitoneal debridement. And the third step is the surgical necrosectomy. So, of course, surgical necrosectomy is a different question altogether. And before 4 weeks, why 4 weeks? Even 6 to 8 weeks, also surgeons are quite scared of, because even if the wall has formed, that wall is not strong enough to withstand the resistance of the tissue plane during surgical dissection. So that becomes a very much challenge. And as Shobik said, that without any features of obstruction or anything, it becomes a challenging situation. But having said that, is it clear, Sadiq? I'm coming to you, Sadiq, with this question that in practical terms, whenever there is acute pancreatitis, even the Pointer study had found that on even 1/3 of the patients, 35% of the patients recovered fully with antibiotics alone. And even this study, which combined both organ failure and infection, did not find any difference. So do you think that by adding, by any intervention, unless it is calculated enough, is more likely to add to complications? Because although this study didn't rectify, but there were more complications in of early interventions, if you see the numbers which Chetan had presented.
So the overall complications rate were very high in the intervention group.
Procedure related
Yeah,
complications.
just
Yeah,
Anirban,
overall.
just a small correction to the question. I think serious adverse effects were the same, but definitely
Yes,
minor
exactly.
adverse effects were there. So yeah, I mean, your question is correct, but actually, if you look at the thing, it was more like minor.
Yes.
But yeah,
So the
so that's
overall complication rate were higher in intervention group, but the serious adverse events were similar in both the groups. This is what the study says.
So
Now,
when we talk about procedure related complications, one is the disease related complications, which of course they counted and it made no difference. But if the procedure related complications are making a difference, I think that do you think that it is good to have a conservative approach, to err on the lower side?
yeah. If this study could have been shown the data that how much percentage of patient in each group have the procedure related complications, and as they have shown that in patients who are enrolled to the control group, more than means 40% patients do not require any intervention at all. So this is a very handsome number.
Exactly.
So sometimes the intervention could means adversely affects the outcome.
Yeah, but anyway, Shobik, in spite of all this, some
sir, I want to
patients
add.
will. Yeah.
So before that, I want to add one thing, as Dr. Sadiq has said. So if we look into the table 2 little closely, and the outcome is reported at day 14, the death and organ failure at day 14. So there is almost 11% difference of death and persistent organ 14 in intervention. So as these trials are designed to look into the efficacy, they are not look into the difference in the small difference in complications. like serious adverse events or adverse events, they will be not picked up by this kind of study designs. Look into the table 2, the mortality and organ dysfunction at day 14. They were clearly higher in the early intervention group. Obviously, the statistical significance was not reached because of small sample size, and study is not designed to do so also. So it would have been revealed.
So, anyways, we got your point, Shobik, although your voice was breaking in between, probably because of unstable net. Sunil, now I will come to Shobik with one more question, that when we consider a composite outcome, with a composite outcome which has mortality and which has major complications, and the number of major complications are more than 2, is it possible that we may be able to detect difference? Because if the contribution of one of any of those major complications may be too much, and we will come to appreciate it in a bigger magnitude.
Yeah.
And if any of
So you're asking, is
So
composite outcome more sensitive in picking up the difference, isn't it?
in
Kind of.
this setting, in this pancreatitis
Yeah, I
setting.
think definitely it would be more sensitive, but it may be difficult to differentiate which of the 3 or 4 outcomes which we have combined has actually contributed to the mortality. Probably, but yes, it probably will make it more, as in, improve the sensitivity of picking up the problem, especially, and also you don't need a larger study. So it increases the power of the study by putting a composite outcome into the picture, and perhaps helps in also finding the difference, because for a long time we were only looking at mortality, and many times mortality may not be the only outcome we'll have to look at. We'll have to also look at the, as you said, major adverse events come
Morbidity,
along.
yeah, right.
Yeah,
Yeah,
morbidity
Shobik, you want
outcome.
to add?
So which is
Shobik?
probably better done in a composite outcome.
Yeah,
so
Shobik.
when someone is using composite outcome as a primary outcome, it is very commonly done in particularly, as Dr. Sunil has pointed out, to increase the power of the study. Yes, that's right. But when you are including multiple outcomes in the primary outcome, every outcome should be of equal weightage. Like if I include mortality with a stage 1 AKI, they are not no way comparable. So we are including multiple small outcomes inside the composite primary outcome. If all the outcomes are equally important, yes, definitely that is useful. Otherwise, it actually increases the rate of false positivity. So that we need to keep in mind. The classical is that the last year the trial was published in AGM by CMC Vellore. It was a Wellcome Trust sponsored trial which showed the benefit of dual antibiotic in patients with scrub typhus, if I'm not wrong, and it showed as a outcome difference in the primary outcome. So that study included mortality and improvement in the organ function, or sorry, the persistent organ failure, or in the primary outcome. And one point of their primary outcome was any GCS other than 15, which is very common, which could be because of several reasons in intensive care unit. So mixing outcomes of different severity, of different importance is wrong. That needs to be taken care of when someone is designing a trial.
Perfect. Well said. Dr. Sadiq, I want to point out one another point in this study. If you are, if Sadiq is not there, okay.
Yes.
So, if that of this study is that there was a difference of only 8 days, which the authors have also pointed out that in discussion as a limitation between the control group and in the intervention group with regard to intervention. Now, do you think that it is something which has been which is really important, or it has been overinflated? Because this is not, and 8 days is a reasonably good margin, and it is not something which can actually affect the data distribution between the patients in the two groups.
So the authors have presented the difference in the intervention days, the days in the difference in intervention between two groups.
Yes.
So it was only 8 days. Means in the control group, in the intervention group, the intervention was done 8 days earlier than the control group.
Yes.
It is a possibility. Ideally, for the acute pancreatitis, the delayed intervention is done either in the 3rd or 4th week. And
exactly. So when we are talking of a situation which is navigating from more than 4 weeks, from starting from 2 weeks, and finally you're coming across a difference of 8 days, that 8 becomes a negligible number, isn't it?
Yes, sir. That is negligible, definitely.
Exactly. So Sunil, I'm coming back to you with this regard to if you want that this population, which has been spread across 5 hospitals, what they call as the tertiary care hospitals in China, in order to achieve an end result, what we need is the standard of care has to be very important. Do you think that if we increase the number of sites, however good they may be individually, but the difference in standard of care may become more and more important, and that might diminish the scope or the utility of the study?
Yeah, so it could work both ways. One is definitely the scope of the study, as you said, might be diminished, but also in a much larger or with more number of centers, it may be hard to really get the proper standard of care across so many sites. So in that way, I think the
Probably the numbers are also
numbers,
important.
yeah, numbers would have
We
been more,
need to
but
have
also the
more.
variability could have been higher. So this is probably not one of those what we would consider in today's world as a pragmatic study per se, because most times when we talk about a pragmatic study, we would leave the other care or the other varieties of care to the local centers. But that is probably a little more better controlled here because these are only 5 centers. But on the whole, I think a larger study would have also caused us a little more dispersion in terms of the standard of care and other variables.
Yeah,
So
Shobik,
I
would
want
you
to
like to
add
add?
one thing. So regarding the standard of care in multicentric study, so if we look into the large studies published in NEJM or JAMA, they have very standard statistical practice. The practice of reporting multicentric study, the way the authors reported here is probably not the best way to report. Actually, in this kind of scenario, when you are expecting a heterogeneity at the care level, like the patients were randomized at the centers, and we are expecting some degree of heterogeneity in the standard of care, the best way to report to use a mixed effect model to look into the random intercepts also. So
They
the
use
one particular
general
strategy.
linear. They use general linear.
So in that case, using so in that case, it will be using a mixed effect model will be reasonable approach to look into the heterogeneity and the standard care, whether it is actually whether it exists or not. That can be done statistically.
So Sadiq, I go to you once again, that if you think that this study could have been improved, could have been a better, what would have been a few points which you would have felt that this study could have been better if they have put note into certain points?
Regarding the inclusion criteria,
Okay.
so if you really want to assess whether the all the infected collections should be drained, because in the control group, if we see more than 40% patients, they improved without intervention. That means all the collection do not require intervention. So if the inclusion criteria could have been more robust, so that that can be applied to a larger number of population, clinically important population, that would have
Exactly.
been better.
So one is the inclusion criteria, and that is the
Yes.
point you want to mention.
Yes, sir.
Okay. And do you think that a longer follow-up period would also be of more use or benefit to understand rather
Sir,
than
anyway, they have reported the 90-day mortality also.
90-day
So how
mortality
long?
was a secondary outcome, not the
Secondary
primary?
outcome. Yes, sir. Yes,
Yeah.
it was secondary outcome.
So if you go to
I want to add, sir, one thing.
Yes,
So a larger sample size will be required because the study is underpowered. They assumed incidence of composite outcome was around 50%,
50%.
but actually it is 30%, 33% only. So obviously it is an underpowered study. And probably if we continue the study in future also, if you do probably the study will be futile. As of now, the present the data which is available in this particular study suggests that a future study in this particular intervention will probably be futile and even harmful.
Yeah, very true. Pradeep, if you are there, I can ask you a question, or if you are
Yeah,
not
tell me,
there.
Anirban, I'm there. Tell me.
So if the as per the studies, if you see the authors, what they have done in their procedure, that they calculated the volume of the drainage, and when it was removed the drain when it was less than 50 ml per day for 3 consecutive days. Now, this criteria, do you think is very practical in Indian scenario? Do you find our intervention radiologists happy with that amount of fluid on the drain normally?
Yeah, see, I mean, honestly, Anirban, this study is actually flawed because as per the standard guidelines, this sort of drainage is not encouraged, isn't it? I mean, that is the sort of a standard of care that you wait for the walling off. If you look at the recent guidelines that has come, the walling off is needed, and that is when you intervene. So maybe as Sauvik rightly said, doing such interventions repeatedly and expecting a drainage possibly is more harmful than any benefit. Although they have used percutaneous drainage, repeated drainages definitely I would believe is more harmful, and it is against the standard of care at this point of time. So I agree that we should not embark on doing such trials which may be causing more harm than any benefit. I'm surprised that it didn't cause much harm for these patients.
Yeah, well, Chetan also mentions that resolution of organ failure could have been an important outcome if they could have chosen. I partially agree, but yes, definitely it could have been that recovery also have been here. But when you talk about a simple PTBD in your center, Sunil, how do you ratify? Means how you decide that when the catheter needs to be removed? Is it purely on the basis of the volume, or
No,
is
no,
it
no. I think
also on the basis of?
definitely reversal of the organ failure. I mean,
Exactly.
biochemical parameters plus the volume, of course. In fact, only if the volume goes down, we actually think is that PTBD blocked. So we also,
Exactly. So these
yeah, yeah.
secretions often
Mm.
block the drainage, and even that time, even if you are getting a distended abdomen and everything, it is not possible. But as Pradeep has said, I also seek your opinion that this such interventions may become risky. But do you think that when there is a rising intra-abdominal pressure going towards abdominal compartment syndrome, are we left with any other choice rather than drainage in desperate scenarios? Because we know that when it is progressing more than 20 millimeter of mercury, it is pertaining with abdominal compartment syndrome is likely.
So I think it depends on what is the cause of the abdominal compartmental syndrome, and most often it will be a large amount of ileus coming in. Because if it is a large collection causing, then maybe there is some role for what you are saying.
Yeah,
Yeah, but if it is just a secondary ileus or something of that nature, I'm not too sure how much putting a drain will help. In fact, in that option, just maybe doing a laparostomy, leaving the abdomen open, may be a much better way of dealing with it, because you're only sort of allowing the decompression to happen, but not really meddling with the actual pathology happening down there. And also, I think if you look at it from a surgical perspective, I'm sure most surgeons will be very not very happy to go in and start sort of prodding around with an inflamed tissue which has not yet completed its process of inflammation.
nobody is going to.
So yeah, it's not going, because as you rightly said, tissue planes will be very hard for them to identify, and these are
I
all largely retroperitoneal, and as it is, you know how difficult retroperitoneal structures or
exactly.
retroperitoneal problems are. So I think largely I would agree with what Souvik and Pradeep said, that we just stick to what we are doing now, and I think we have right now enough data in terms of, though I mean may not be RCTs, but enough volume of data to just say that whatever we have been doing till now in the recent past has been probably paying dividends, and maybe just continue the same line of management unless there is infection. I mean, if there's an
Yes.
infection, it's a different story, because source control becomes a priority. Otherwise, I think sterile inflammation is better we don't go prodding around.
I will come to Sunil once again. Before that, I want to go to Sadiq. Sadiq, when you call evolves around infection control, we know that we have a handful of antibiotics which reach the pancreatic tissue. We have the carbapenems, we have the quinolones, and we have the metronidazole. Out of which metronidazole and quinolones most often the bugs are it won't work. So we are left with carbapenems. Now, in the growing scenario, if we want to treat infections only, do you think that only carbapenems are good enough as weapons to combat the infected pancreatic necrosis?
Definitely not as a single agent. You should add either polymyxin or another agent which could take care of gram-negative bacteria, which is more prevalent in your ICUs. So a combination of carbapenem with polymyxin or tigecycline may be of good choice.
Yeah, Sunil, any comments?
Sorry, can you just, I missed the question.
I asked that we know that we have only 3 groups of antibiotics that really penetrates the well into the pancreatic tissue: the carbapenems, the quinolones, and the metronidazole. So out of this, we are almost out with quinolones, and we become unreliable metronidazole. So we are only left with carbapenems. Now, do you think that they become really handy in infected acute necrosis, infective necrosis to be used, or do you, in our scenario nowadays?
Yeah, I think that will still be the first line. Well, I'm not sure about combination. Probably in the when the first wave of antibiotics, probably only carbapenems, but subsequently, of course, we might end up needing more and more. And today, as you know, anything and everything after 72 hours is Klebsiella, which is often XDR. So I think we end up anyway adding pragmatically on the ground. I think it's a different story. We end up adding polymyxin anyway. But in the context of sterile or a pure situation where we are just expecting an infected pancreatic sort of necrosis, probably carbapenem will be my first choice for now. Again, if you start splitting hairs with statistics, it will be probably imipenem, because that's the one where most data is available. But of course, we will leave it as carbapenems as of now. Yeah.
Yeah. So we have very little time left. So before we end, I am going to ask one last question. It will be the same question to all our panelists. And I will start with Pradeep. What are the 2 important messages that you can take from this study?
Yeah, Anirban, so honestly, I am a critic, so I didn't find this study useful in any way because the pointer study had already done and dusted in 2021 that early intervention does not offer any benefit. So the standard, I would stick to standard guidelines, which is walling off. I think that walling off is an important entity. There is a lot of physiological basis as to why we wait for the walling off the necrosis. But maybe a desperate measure may be needed, as all the esteemed panelists said. When there is an infected collection, you would possibly think of intervening early. But otherwise, I would wait for walling off and embarking on such interventions very early on when there is so much of cytokine storm and so much of inflammatory process is happening may possibly cause harm. So I'm surprised that studies did not show harm in these particular. So I would rest my case at that with these inputs.
Sunil, 2 important messages which you get from the study.
Yeah, I think firstly, probably this was a part which was not touched. I mean, if you look at lots of pancreatic data that we have, yes, we did have some data all coming from retrospective cohort-based kind of analysis, but probably this has now shown that what we are doing is right and probably stick to that. I agree with Sauvik and Pradeep, what we had mentioned previously that, as the author said, should we do another RCT? I think it'll be a waste of time, just wasting money and probably getting the same negative data. Just a small thing, I think Chetan was mentioning about resolution, but there is an indirect mention of that in the secondary outcome where they looked at death or presence of organ failure on day 14. So kind of it covers that angle as well. But unless you wanted to be that present in the composite outcome, yes, we could look at that also, but it may not change very much the current, I think, knowledge that we have. But give and take, I think no practice changing kind of, what you call, no practice changing kind of discovery from this study. So this probably confirms what we are doing is correct and keep doing it. That's about it.
2 important messages, Sadiq.
Sir, as Dr. Sunil highlighted that till now we have a large number of data on the pancreatitis. And with this study, we have a higher level of evidence to follow what we were already following. And exactly, this means in patients with pancreatitis are as it involves multiple organs. So resolution of organ failure is our primary target. Apart from the disease itself, the organ should also be resolved. This is the thing which we should take care of.
2 important messages that you can take from this study.
So, Dr. Pradeep and Dr. Sunil has already pointed out. So, don't intervene. Look closely. That's it. And don't do this study again. There's no need.
Yeah.
Don't
So
waste
that is
waste your
and
money on that.
And I will also, it will not be, I won't be doing justice to Chetan if I, without giving Chetan 2 important things that you learned while preparing this journal club article.
Yes, sir.
That we
Sir,
take note
on
of.
this, yes, sir, timing trial as well as pointer trial, sir. They clearly told early intervention is of no mortality benefit. And ACG 2025 guidelines also says after 4 weeks, vault of necrosis better to drain. Before 4 weeks, if it is causing worsening the organ failure or causing gastric outlet obstruction or biliary duct obstruction, then a risk benefit ratio we have to see and we have to intervene. Otherwise, no early intervention, sir. No mortality benefit.
Okay, thank you. So friends, thank you for being with us in this discussion. So whether it is pseudocyst or whether it is walled off necrosis, whether it is after acute peripancreatic collections or whether it is acute pancreatic necrosis, the results still show that early intervention doesn't make any big difference in the outcome, but probably adds a little bit to some of the procedure-related complications. Till we come with some more interesting article in our next episode, that is on the 4th Thursday of the month. From all of us in GICS Rapid Journal Review, thank you, Shubhratri, Shabar Khayat, good night. And once again, thank all the panelists and our experts. Thank you very much. Hope to meet again soon.
Thank you. Thank you, Anirban. Thanks all
Thank you, sir.
Thank
panelists.
you. Thank you, sir. Good night. Good night.
Thank you, sir.
Thank you, everyone. Good night.
Thank you, sir. Good night, sir.
Good night. Thank you.